Hello, this is Kim Jong-gil. Today's topic is problem list in orthodontic diagnosis. This is a 22-year-old female patient with chief complaints of protrusive lips and anterior crowding. In general, lip protrusion can be assessed by drawing a subnasal vertical line in natural head position and comparing the relative positions of the upper and lower lips and pogonoion. In the patient's panoramic X-ray, fully erupted. Upper and lower third molar and generalized root shortening in the lower arch are observed. In intraoral photos, the lower molars are lingually inclined, and the lower midline is shifted to the left due to Hauff class 3 canine K on the right and class 1 canine K on the left. A slight asymmetry is present in the PA X-ray. ODI 56, APDI 89, and CF 146 indicate a class 3 high-angle case. With respect to the L-line, the upper and lower lips are slightly retruded and protruded, respectively. So this is a class 3 high-angle patient with normal FMA of 24 degrees. Flat UOP and POP of 5 and 6 degrees are characteristics of class 3 malocclusion. The upper incisors are proclined 124 degrees. The lower incisors have normal inclination of 92 degrees. And the interincisal angle is 119 degrees. The upper lip is retruded -1 mm, and the lower lip is protruded 0.8 mm from the L-line. This is the checklist I use for problem lists. 1. Chief complaints. It is important to acknowledge what patients want from orthodontic treatment. 2. Oral hygiene evaluation. The patient's ability to maintain oral hygiene should be evaluated. 3. Growth evaluation for TMJ evaluation. 5. Functional matrix evaluation. 1. Nasopharyngeal airway. Any ENT issues such as enlarged tonsils or adenoids. 2. Bad habits such as mouth opening. 6. Face evaluation. 1. Facial asymmetry. Facial appearance always should be evaluated from the front, first for asymmetry and lip canting. 2. Profile. 7. Panorama and PA evaluation. 8. Dental evaluation intraoral model. 9. Cephalometric evaluation. 1. Skeletal pattern analysis. 2. Occlusal plane analysis. 1. The patient's chief complaints are crowding and protrusive lips. 2. Oral hygiene is good. 3. Growth evaluation is unnecessary for adult patients. 4. There is no particular problem with the TMJ. 5. Lip seal is good. 6. Profile is acceptable. 7. In panoramic and PA X-ray, the upper and lower third molars are fully erupted, and posterior available space should be evaluated. 8. In dental evaluation, canine K is Hauff class 3 on the right, and the upper midline coincides with the facial midline, while the lower midline is shifted to the left. 9. According to cephalometric evaluation, the patient has a class 3 high-angle skeletal pattern, interincisal angle of 119 degrees, and flat UOP and POP. At first, it is not easy to create a problem list, so this checklist can be useful in step-by-step thinking process for problem lists. Then a practical problem list for this patient can be devised. You can come up with possible solutions and organize them. 1. Protrusive lips are treated with extraction. 2. Anterior crowding is treated with extraction as well. 3. Habit control is needed to treat lateral open bite. 4. Posterior cross bite should be treated with non-extraction approach if possible. 5. The eruption third molars can be extracted. 6. Non-extraction treatment is recommended for lingual constriction of lower molar. 7. Because of generalized root shortening, it is advisable to treat with non-extraction approach and shorten the treatment duration as much as possible. As you can see, extraction treatment is suitable for some criteria but non-extraction for others. After listing the problems and possible solutions, they need to be organized for proper treatment of the patient. Then pros and cons of non-extraction and extraction treatments should be considered. By extraction treatment, protrusive lips can be resolved. On the other hand, non-extraction treatment is favorable for posterior cross bite, and space can be gained by the extraction of third molars. In addition, lingual constriction of lower molars and generalized root shortening are good indications for non-extraction treatment. I always organize possible treatment plans into a couple of options, and then think about the problems of each treatment plan. In orthodontic treatment, you should consider not just the benefits, but also the problems of the treatment and discuss with the patients in order to minimize possible problems. What are the problems of non-extraction treatment for this patient? The patient has protrusive lips, low CF, and proclined upper incisors with 124 degrees. On the other hand, what are the problems with extraction treatment? The roots are short, and curve of Wilson and curve of Spee will become severe, which in turn lead to bite deepening. Posterior cross bite will worsen, and a total of 8 teeth will be missing if the third molars are extracted as well. During diagnosis with the patient, facial asymmetry is explained first. Then among the two possible treatment plans, the one that is more suitable for the patient is suggested, which is to extract the 4 third molars. Lastly, tongue crib retainer will be used after the treatment. These are the post-treatment photos. Favorable occlusion was achieved by the extraction of only the third molars. The next case is an 11-year-old male patient with anterior crowding and protrusion of upper anterior teeth. With regard to the subnasal vertical line, the maxilla is slightly protruded, and the upper midline is deviated. In panoramic X-ray, congenital missing of teeth 23 and 24 is observed, and as a result, the upper midline is shifted to the left. The deciduous upper left canine is retained, and there is a lower anterior slight crowding. In PI X-ray, shorter left mandibular ramus is observed, and there is a corresponding lip canting. Presumably, the congenital missing of teeth 23 and 24 caused an undergrowth of the left maxilla and subsequent underdevelopment of the mandible on the left side. As a result, the midline is shifted to the left. ODI 77A PDI 80 CF 157 indicate a Class 1 low angle pattern for this patient. A PDI 80 indicates Class 1, CF is a large value of 157. FMA is a low value of 19.6 degrees, and the UOP and POP are normal. IMPA is 98 degrees, which means labioversion of the lower incisors, but the interincisal angle is 125 degrees. If the interincisal angle is low, the chance of premolar extraction increases. With regard to the L-line, both the upper and lower lips are protruded, 4.6 mm and 3.6 mm, respectively. Let's take a look at the checklist for problem list for this patient. There are not any problems with oral hygiene and TMJ. From the front, facial asymmetry and lip canting are observed. The maxilla is prognathic in the profile view. An unusual finding from panoramic X-ray is the congenital missing of teeth 23 and 24. The canine K is half class 2 on the right, and as a result, the upper midline is shifted to the left, while the lower midline coincides with the facial midline. The skeletal pattern in class 1 low angle, and the interincisal angle is large with 125 degrees. Here is the practical problem list for this patient. 1. Protrusive lips are treated with extraction. 2. Facial asymmetry can be treated only with surgery. No one has a completely symmetrical face, so it is important to explain to the patient. 3. Midline deviation can be treated with either orthodontics alone or with surgery. 4. For congenital missing of teeth 23 and 24, space can be opened up in this area for dental implants, or the extraction space can be closed. 5. Lower anterior crowding requires extraction to treat. 6. But since CF is high, non-extraction treatment should be carried out if possible. If there are congenitally missing teeth in an extraction case, autotransplantation should be the primary option to consider, and the timing of treatment is crucial in this case. This patient has a congenitally missing tooth 45, and the crowded tooth 25 can be autotransplanted to this area. Timing is very important in case of autotransplantation. The ideal time to transplant a tooth is when the root has achieved 1 of 2 to 3 of 4 of its final length. That is, the root should be sufficiently developed, but not too developed either, so keep in mind 1 of 2 to 3 of 4. By transplanting a tooth at this stage of its formation, acceptable development of root length can be expected. So this patient had tooth 25 autotransplanted as tooth 45. These are panoramic X-rays of 1 month and 7 months after transplantation. Orthodontic treatment became easier with autotransplantation. In the maxilla, there is only 1 premolar on the right, and since there was not enough space for tooth 25 to properly erupt, it was appropriate to be transplanted into tooth 45 area. Bear in mind the autotransplantation in case of an extraction case with congenitally missing teeth. However, autotransplantation is not a good option for this patient because of almost complete root development of donor tooth 15 and missing deciduous molar, which leads to an excessive bone removal at the recipient area. Facial asymmetry should be explained to this patient as well during diagnosis. There are 2 possible treatment plans, which are extraction of the tooth 14 and the lower second premolars, or just the tooth 14 and no extraction in the mandible. This premolar space can be closed. Deciduous canine can be used until it needs to be extracted, and an implant can be placed. What are the problems of the extraction of the lower premolars? First of all, CF is high, and since the patient already has congenitally missing teeth, he and his parents are reluctant for additional extraction of teeth. On the other hand, what is the problem with the extraction of only tooth 14? Protrusive lips may not be sufficiently resolved. However, because of high CF, it was decided to extract only tooth 14. These are the post-treatment photos. Acceptable Class 1 canine K and Class 2 molar K are achieved. The profile is acceptable, and the mandible was able to be treated with non-extraction approach due to high combination factor. If combination factor was low, non-extraction treatment would lead to more lip protrusion and labioversion of the lower incisors. So premolar extraction would be likely. In this lecture, we discussed how to produce a problem list and apply for clinical use. Thank you for watching.